Hey guys, I wanted to ask you some questions about a case that I saw. So this is a case of a 25-year-old woman who presented to the community health center for treatment of an abscess on her right leg. She has a long history of opioid use. She started using oxycodone that she used to steal from her grandmother several years ago, and eventually progressed to using IV heroin. She stopped using drugs for a period of time, for about 2 years, after entering a residential treatment program where she was started on buprenorphine. She recalls that at that time she had tested negative for HIV, and she was also told that she had tested positive for hepatitis C, but during the time that she was in the residential treatment program, she apparently cleared it without treatment.
So she was HIV negative, she was told, and then she was told that she had hepatitis C, but that during the time she was there, she cleared it.
Correct.
Okay.
And that was without treatment.
That was without treatment. So because she was there for 6 months, and so she was told that by the end she had cleared it.
Got it.
She moved back to her hometown about 8 months ago, but was unable to find a provider for buprenorphine, which is not an uncommon situation. As a result of this, she ended up relapsing and started using IV heroin again. She tries to use clean needles and syringes when possible, but it's not always possible. Sometimes she shares with friends that she says are clean as far as she knows. So she's not too concerned about HIV or hepatitis C reinfection. Sometimes she admits that she has sex in exchange for drugs and doesn't always use condoms when this happens. So her example is pretty unremarkable other than the abscess in her right leg. Now, my question was about testing. So, based on what I've told you, what would you want to order at this point on somebody like her? Would you want to go through an HIV test, a fourth-generation HIV test? Would we need to do a hepatitis C antibody test? Would we do would we just go to a hepatitis C RNA test? What do you think?
Yeah, well, it seems like the abscess is relatively easy to deal with, right? But she's engaging in ongoing risk that we need to figure out. Could she be HIV infected? So we definitely need a fourth generation HIV antigen antibody test. And she could certainly be hepatitis C infected. Her antibody will probably always be positive.
Right.
So we really need to look for a hep C RNA viral load.
Good.
Yeah, I like the idea of the antigen antibody test, and I'll tell you why. So this, of course, is a sandwich with, you get part of the virus and you also get the standard antibody. She's actively injecting, and so she's someone whose risk could be that she didn't acquire HIV sometime after she got out of the rehab center. It could have been 3 weeks ago.
Right.
If she has ongoing exposure. So you'd really want a test that has the smallest window period for figuring out, did she get recent infection? We want to preclude as much as we could recent infection, given she's actively using and has this abscess from possibly shooting into her leg. So I think the fourth generation or combo or duo test is the perfect test to order here for her HIV.
Right.
Hepatitis C is also interesting, though, what to do if she really has been exposed in the past.
Right. Yes, and in this case, I think something that is an important point is that reinfection can happen in these patients, but as you mentioned, hepatitis C antibody will remain positive for life. So in this point, to really know if we see reinfection of hepatitis C, we need the hepatitis C RNA.
This is really important. So this is, at my hospital, this is a pet peeve. Once someone tests positive for hepatitis C, on their chart, it continues to say on their problem list, hepatitis C positive.
Yes.
And literally, that is true. Because just like varicella or measles or mumps, you get exposed, you get an antibody response. That antibody response persists for the rest of your life, pretty much. And so even in people, the 20-30% who clear their hepatitis C all by themselves, right, they still have the antibody that's positive. And so it's deceiving because they are positive, but they don't have any hepatitis C in their body. And it sounds like maybe in her case, that's what happened, that she was one of the lucky 20-30% who, under observation, had some viral load for hepatitis C. It was followed and over months, dropped, and then went away. And she's cleared it. That would be great, but that doesn't mean she couldn't get it again. And the antibody doesn't help us, right?
Right.
Yeah.
Exactly.
I also wanted to add that because she's exchanging sex and having very high-risk sexual behavior, she also needs STD testing. So, looking for syphilis, gonorrhea, chlamydia, and so there's a number of tests that we can think about how to best order.
Good. What other tests would you do? Would you check for hepatitis B or hepatitis A? Yeah.
I mean, she certainly, if she's not immune, deserves vaccination, so that's going to be important. And if she has chronic hepatitis B, she might be someone that we would treat.
Right.
This is tricky too, and so different people do different things. I think for most of what we do in my clinic is we like to get a hepatitis B surface antibody and surface antigen. And if both of those are negative, we will vaccinate people. The core, and so hepatitis B testing is completely confusing to every medical student and every nursing student. So we know that it's difficult to understand. The big issue, of course, is are you measuring antigen or antibody? Antigen, part of the virus, antibody, the body's response. And as long as you can keep those A's separated in your mind, if you find antigen, it's bad. That means the virus is present. If you find antibody, not necessarily. It could just mean exposure. Core antibody, which confuses a lot of people, is squiggly, right? Because some people can have core and it's a false positive, so we don't bet the farm on the core. That's why I like antibody, antigen. If your antigen is positive, you have virus present. That's not good, and we've got to deal with that. If you have antibody present, that surface antibody, that's the cavalry that came over the hill. I'd want to know that, and you're immune. So that's the really two key things. And if they're negative, so in her, for sure, what can we prevent, right? In this very challenged, very at-risk individual, we don't have a vaccine for hepatitis C. We don't have a vaccine for HIV, although there's other things we could talk about that maybe we can do. We do have a great vaccine against hepatitis B, and she's completely at risk for hepatitis B. So I agree. Hepatitis A, I don't feel so strongly about, but definitely that. And I would also just mention syphilis, because while we think of syphilis nowadays more among men who have sex with men, and that's where we're seeing it, there's also a big upswing in congenital syphilis, and if there's an upswing in congenital syphilis, that means women are acquiring syphilis too. So I would definitely get an RPR, and I think people would often forget about that, in this kind of case. And then a tetanus shot and all that great other stuff that we could do to prevent badness, because she's got a wound on her leg and she's in the ER.
I think the other piece is she's having ongoing injecting and ongoing risk, and she is someone who really deserves, treatment for her opioid use disorder, as well as we're dealing with all these, potential infectious complications of her use.
Absolutely. Yeah, this is great. And so let me take you through some of the results and what we ordered and then the results that we got. So we ordered a 4th generation HIV antigen antibody test. And then also we did a hepatitis C RNA. We didn't do a hepatitis C antibody. We already know that would be positive, so no sense in doing that. We sent hepatitis...
Although, let me interrupt you. So some labs, mine included, many, will not do an RNA unless you have documented antibody positivity. So I don't know if some of the commercial labs maybe will do a reflex, because that would be even better. But yeah, so you might get it, if you try to order a hepatitis C RNA in your own lab, just beware, just find out what the rules are, or you have to make a phone call and I say, I'm worried, I know that they're positive, I'm worried about infection or whatever, or have a documented positive, but just beware, you might get a phone call.
That's a good point. And I think along with that, it's important to also keep in mind that in most settings, including in my institution, then when you send the hepatitis C antibody, there's a reflex to the hepatitis C RNA if it's positive. But that may not be the case everywhere, and especially when there's, if we have point of care testing, in certain settings, which will then give us a result of the antibody, but in that case, not the hepatitis C RNA. But very good point.
And if this is a woman who was tested and cleared in another state, like I think you mentioned residential treatment in another state, you'd want documentation that she has a positive hep C antibody anyway.
Right. Absolutely.
Yeah. So I think we're better part of valor might be I might have ordered it just to see, because it's just our history, and people get confused about their hepatitis A, B, and C. Their alphabet.
Very true.
But I think the testing you did was great, and I'm curious to see what happened.
Sure. So let me take you through some results, and then I'll ask you to help me interpret
Sure.
these results.
Sure.
So the HIV antigen antibody came back as reactive, which then reflexed to the HIV-1 and HIV-2 antibody differentiation tests. And these came back as non-reactive, so both for HIV-1 and HIV-2. So if we stop right there, then how would you interpret this at this point? And then so what would happen next to help us figure out what the actual result means?
Yeah, so I think there's kind of two possibilities here, right? One is that she has a false positive HIV antigen antibody test. The other, although the window period is very small for this fourth generation combination testing, she is having ongoing risk. So if we think she was infected in, let's say, the past 7 to 14 days, then this could be a result like you'd see in a window period, and you'd really need an HIV viral load to tease that out. But it doesn't sound like, from what you said, like she had many symptoms of acute HIV that would point you in that direction.
Yeah, exactly. So nothing that would make us suspect, this could be acute HIV. Although, an important point is that the presentation of acute HIV can be very nonspecific. We talk about flu-like symptoms, sometimes a rash, possible sore throat. So unless we're asking the questions, we may not elicit the history that to really be able to say, could this be acute HIV?
It's a key point, because I think the problem with this test is great. The window period is down to maybe 10 days.
Yeah.
Right.
Checks for both antigen and antibody, and that's why it's able to do that. But the result doesn't tell you which was detected, which is positive. So when you get a positive result, you don't know if it's the peanut butter or the jelly, but you just know that one of them is present. So then you have to do some sleuthing. And you did that. You did the antibody test, a standard antibody test, which should have been positive if the antibody part of the combination was what was dinging and signaling, and it was negative. So that's concerning, especially in this setting, because then it does mean, like what you said, she might have antigen present, and that would be concerning for acute HIV. And I'm very worried about that now. So I think you're right. A viral load test here would be very helpful.
Right. And at my institution, then what usually happens when we have these results is that there will be a reflex to an HIV nucleic acid test, which will then help us answer that question. Is this acute HIV, or is this a false positive result? So fortunately for her, in this case, then that reflex HIV RNA was non-reactive. So in that case, then what's your interpretation in that case?
Well, then I think you're left with the idea that this was probably a false positive, although she's certainly at high enough risk. She warrants repeat testing in the next 3 to 6 months. She's someone who would be high, maybe even longer, but she's high enough risk that you'd want to repeat testing in her at some sort of regular basis.
Absolutely, and I think it's important to highlight to the patient that she is at an ongoing risk of HIV, and the fact that she tests negative now, if her behavior then remains the same, then she will continue to be at risk. So, repeat testing is very important. And then talking about prevention, which is something that we can get to.
What I see with some of these false positives, though, that was a little different than your case, is that if your antibody, which is what we think is being false positive here, was false positive on the combo test, it might also be false positive on the standard antibody test that you would do. That's just the single antibody without the combo. So sometimes we get faked out because the combo test is positive. You do the antibody test, and it's also possibly a false positive because this person's making antibodies. Women who've had pregnancies, multiple pregnancies, can make multiple antibodies. There's other reasons people can have false positivity. So you just got to be careful. A trick sometimes is if it's done at your local lab and not necessarily at like a commercial lab, you could sometimes ask a little bit more information about how positive was positive, because there are some thresholds, and there's some data, published data, that show that the threshold above which that they call positive, within that range, if it's at the lower range, the chances of false positivity are much higher, whereas if it's at the higher end of the range, the chance of a false positive is actually very, very low. So that may be another thing, is just to talk to your lab about the dynamics of the test and the result that you got. And just if they say it was just barely, at this level, you can maybe feel a little bit more assured that that's in the zone where we see a lot more false positive signals than we do when it's much higher, when it's much rarer to have a false positive.
And is that what helps you tease out if someone has, let's say, an antibody that's positive, but an RNA that's negative? You don't know if are they an elite controller, or are they really have a false antibody test? So it's that level that can sort of help you tease it out.
And it's confusing because you'd think if someone's an elite controller, meaning they were infected recently, then their virus dropped down and all by themselves, and they were able to suppress it, but they still have HIV infection. The RNA may not detect it, but your P24 shouldn't be positive. But your antibody could. And so I think you could be faked out in a scenario where your RNA is undetectable because you're one of these very rare elite controllers who's been infected and you've controlled it, your antibody's positive. Again, the reflex HIV-1, HIV-2 antibody test you did then should have been reportedly positive.
Exactly.
It wasn't.
Yeah, in that case, to have an elite controller, then that
all antibody tests would be positive.
Right. Exactly.
Yeah.
Good. So I'm glad we worked out how to interpret that result. So then when we checked her hepatitis C RNA, it came back at 344,000 international units per milliliter. So in this
either
case,
she wasn't cleared, and she's wrong, or that she got the wrong information, or she's confused, or she did clear, but maybe got reinfected.
Right, and we know that a significant proportion of people infected with hepatitis C do clear spontaneously. It's it can be up to 35%, and we know that this is more likely in women, and that once somebody has cleared infection the first time, they're also more likely to clear the next time, but not necessarily the case. Now, what is interesting here is that we don't know whether this is relatively acute, and then is she likely to clear this, or does she now require treatment? What do you think?
Yeah, I mean, she could be one of those, like we said, those 20 to 30% who clears again, and so some people would say watch and wait. However, she's engaging in ongoing risk, and she could potentially deserve treatment really as prevention. So treatment, getting her Hep C viral load cleared so she doesn't transmit to others. The other thing I was just going to note is that unlike HIV, Hep C doesn't have a latency phase. So this is not, she sort of cleared and then rebounded, right? We're thinking this is more of a new infection.
This is a tough one. I'm thinking about this has evolved a little bit, and I definitely would say I'm more leaning towards treating, even if there is a possibility this is more recent infection or reinfection in this case, and that she can clear herself. There's an 80% chance she won't clear herself, or maybe 70% chance she is now infectious. I think coupled with whatever we can do to get her help and support to stop sharing needles, to stop it would be great if we could get her to stop shooting and stop using substances, but even if we can get her to access to clean needles and syringes, because then that's analogous almost to I'm using condoms, if we're talking about a sexual analogy. So I think harm reduction makes a lot of sense here, and treating her to get this virus out of her system so she doesn't pass it on to someone else. How many rounds of reinfection do we tolerate? That's going to be something that we can all debate, and we all probably have our own levels of comfort with that, given the cost involved. But I think this is her first possible reinfection. One tip-off is if we did get results from outside, from the other state, what genotype she had then and what genotype she had now. I think an important point that you mentioned was that unlike hepatitis B, when you get hepatitis C, you don't get immune to it. That's why we don't have a vaccine. That's why we have a vaccine in hepatitis B, because you do get immune to it. So she can get repeatedly reinfected. At some point, people may say, well, how long do we keep treating her? I haven't had too many cases like that. I think it's very rare case of someone who you're just coming in over and over and over again with hepatitis C. I'm sure there's people who see that, but I would give her the better part of valor.
Yeah, and I think that that's also an important point, that even in the population of patients who are actively using drugs, the rates of reinfection are not so high. So even though sometimes that's used as the reason for not prescribing treatment for patients who are actively using
Right.
drugs.
It's not very common.
Right, exactly. So the other results, so we did hepatitis B serologies, and she had a negative hepatitis B surface antibody. Her total core antibody for hepatitis B was also negative, and the surface antigen for hepatitis B was also
She should
negative.
get vaccinated and get the whatever flavor you have of the month, and I think vaccinating her against that would be very helpful.
Right, I think that would be a good idea. And the STI testing that was done, then she was tested for syphilis, and so her IgG was positive, and that reflects to an RPR result, which was then positive with a titer of 1 to 256. So, and in this case, that this requires also some interpretation because we want to know if this is somebody who was previously treated and maybe started with an RPR that was actually significantly higher. But in most states, usually we can check with the health department and then to see if this patient has been treated at some point. In her case, she had not been previously treated for syphilis. So we believe that this is in fact, untreated syphilis infection that she.
And the important thing I think you said was that you had a confirmatory test. Because again, if we say that she may be making antibodies and gives her a false positive HIV test, we know RPRs can be falsely positive as well. So I think if you have a non-treponemal test or another confirmatory test that shows that she really did have true syphilis, I think that's helpful. But I agree, and 1 to 256 is pretty high, so this is bad. And so she'll have to be treated for this as well.
Right.
I've learned recently too that you can not only request prior syphilis titers and a testing history and treatment history from your own state health department or Department of Public Health, but they can also request from other states. So if she, let's say was living somewhere else in this residential facility and had prior syphilis testing as well, you could figure out what happened with that.
Yeah, no, and I think that's a very good point. But in this case, even if you're not completely sure, the fact that that RPR titer is quite high, then I think that would lead all of us to lean towards treatment.
Definitely.
Yep.
And so she was tested also for chlamydia and gonorrhea, and tested negative actually for those. We've discussed then the interpretation of results. Now at this point, what would you do? So we've vaccinated against hepatitis B, given her results. We're now treating against syphilis. Would you then, we talked about the fact that it sounds like we're all considering then treating her for hepatitis C, even though she could possibly clear on her own, but given her ongoing use of IV drugs, then it would make sense to provide treatment for hepatitis C. Is anything else that you would do then at this point? Would you want to refer for is this somebody who would be a good candidate for HIV PrEP? What do you think?
Potentially. I think she probably needs a lot of things and needs to ideally be linked to a place that can care for her in sort of an integrated way, right? So she certainly needs access to harm reduction services like syringe service programs. She needs follow-up Hep C testing, if not treatment. So whether that be through an infectious disease specialist, a hepatologist, or in primary care, however, and then above everything else, the best you can do for her is to get her into treatment for her opioid use disorder with medication-assisted treatment that we know can not only help her, reduce her own use, but also, reduce the chance that she would become HIV infected. So treatment in that way as HIV prevention. She would qualify for PrEP, and we can certainly talk more about that. But she seems like she needs a lot of other things first.
But I would at least let her be aware of it. I think it's really good to know, and I think your points are excellent. Yeah, I think PrEP, she has sexual risk, she has the injection drug use risk, there's data to support both that, so I think she'd be a really good candidate as part of the package of many things that she needs. So I hope that helped.
Yeah, no, it certainly did. So now we're hoping, that we've set up the referrals. So we're trying to get her back in treatment for her substance use, as well as PrEP services. And we discussed the importance of repeating testing for HIV and hepatitis C reinfection at the point after we complete treatment. And I think this case, for me, it showed also another important point with this population. In many cases, the point of access to care, they may not have a primary care provider, and it may be the urgent care, the emergency department, or in this case, the community health center. So we should be aware and then use that opportunity that if a patient may come in for something else, as in her case, she came in specifically for treatment of her abscess, but this presented a great opportunity to then do that testing and then linkage to care.
That's a really good point.
Yeah.
Well, thank you. This is really interesting. Thank you for sharing this one.
Thank you both.
Yeah.
Thank you for joining us. We hope you found this discussion informative. Next, let's summarize the key takeaways as SMART goals that you can implement in your practice. Implement strategies for POC rapid testing in at-risk individuals. Develop comprehensive approaches for prevention and treatment of HIV and HCV in patients with OUD.